Can you see my screen?
Yes.
Okay, very good. So I'm going to talk about a case of hypothenar hammer syndrome that occurred in a cyclist. It's a simple case report, nothing earth-shaking. This syndrome developed, there's an ulnar artery aneurysm, and it was treated surgically. And with a follow-up Doppler ultrasound, studies demonstrated persistent flow. And I'll show you an example of the pathology of this from the case. And we'll talk a little bit about diagnostic and treatment options for this, as well as a differential diagnosis for lesions in the Guillain Canal. So the clinical history is a 65-year-old male presented with a mass in the region of the hypothenar eminence of the left hand. The patient was an avid recreational cyclist who began cycling 40 years earlier, and over the subsequent years accumulated in excess of 100,000 miles of cycling. The cycling was predominantly on the road with a minimal amount of off-road cycling. And although the patient always wore cycling gloves and the handlebar was wrapped, it was not a padded handlebar. The patient presented with a mass in this region of the hypothenar eminence, and a CT scan was performed, and you can see the mass lesion here on the CT. Now, the radiologist that read this report did note that there was a 1 millimeter blood vessel appearing to run through this mass, could not clearly distinguish the superficial ulnar nerve from the mass, but concluded it was most compatible with a nerve root sheath tumor, most likely a schwannoma. That was incorrect. And at surgery, the orthopedic surgeon that performed this operation found this ulnar artery aneurysm in the Guillain Canal, resected that, and performed an end-to-end anastomosis. The pathology of this lesion, dilated aneurysmal artery that's been thrombosed. And there is a neovascularization of this artery. Basically, it's a Masson type lesion. It's an exuberant revascularization of the thrombosed aneurysm. And this is a 31 IPOC stain showing the proliferation of vessels in this thrombosed aneurysm. It's interesting to look at the wall of the artery. The wall of the artery has been replaced with fibrous tissues. And also you see on the EVG stain, a loss of elastic tissue in that thin dilated arterial wall. This is the ultrasound Doppler study 14 months after the operation, and it demonstrates some persistent flow with a triphasic pattern on the Doppler. Jean Guillain, French surgeon, first described this canal way back in 1861, and he's been commemorated with a French stamp for doing that. The Guillain Canal is best regarded as a fixed space delineated by a palmar roof, which forms the top part of the canal, a radial edge, which is attached to the flexor reticulatum, and a floor made up of the flexor retinaculum. And importantly here in the floor, there's a portion of the hook of the hamate bone that makes up that floor. An ulnar artery, the ulnar margin is formed by the attachment of the fascial roof of the canal with the hypothenar muscle. Superficial branch of the ulnar artery crosses the surface of the hypothenar muscle, where its superficial location makes it very susceptible to traumatic injury. And we can see that here. You've got the canal here, and here's the ulnar artery, ulnar nerve. Here's the hook of the hamate here forming the floor. And this is the palmar surface up here. With repetitive trauma, you can see this artery can be susceptible to traumatic injury. Now, workers most susceptible to this are machinists, construction workers, miners, mechanics, anyone that uses tools with their hands. And you can see a variety of tools have been implicated in associated with the hypothenar hammer syndrome. Probably the most common one is the workers who use jackhammers, and you can obviously see there's a tremendous amount of trauma to the hand and the ulnar artery there. A number of athletes, here's an example, a hockey stick held in the hand right over the hypothenar area. Some firearms, particularly repeating firearms, can cause this syndrome. And in our case, the cyclists, if you look at how cyclists have their hands on the handlebars, the little dots here are where the lesion is underlying this. But right over on the drops, when you ride your bicycle on the drops, there's pressure on there. You ride on the hood of the brake levers, the pressure is also there, and on the crossbars, if you ride up on the top crossbars. The diagnosis of this syndrome is physical examination. You can do the Allen's test. Angiography is frequently very helpful, and in this case, CT scan was performed. The hypothenar hammer syndrome has a differential diagnosis. They are both vascular and mass type diagnoses. For the vascular occlusive aspect of the disease, you can look at embolic and proximal vascular disease, as well as local disease with or without associated systemic disease. Proximal etiologies would include cardioembolic causes with embolism to the distal ulnar artery, large vessel disease such as atherosclerotic plaque that could also embolize, and the arterial thoracic outlet syndrome. Local etiologies with systemic manifestations include, again, atherosclerotic disease, vasculitis, Raynaud's, and connective tissue diseases. Because it forms a mass as it aneurysm dilates, you might also consider in the differential diagnosis mass type lesions such as lipomas, schwannomas, vascular malformations. And in this case, the operation was started thinking this was going to be a schwannoma. There is a Allen test for patency of the radial and ulnar arteries that can be performed. You occlude both arteries, have the patient clench their fist, get the hand to blanch, and then sequentially release the pressure over the radial and ulnar arteries to see if there's refilling. It's a good test, but it has a significant number of false negative and false positive results. Angiography was not performed in our case, but if it were performed, you might demonstrate or the actual occluded area. These are CT images. This is our case, the ulnar artery aneurysm, but you can see it looks very similar to a ulnar nerve schwannoma in Guillaume's canal. The symptoms with hypothenar hammer syndrome include symptoms related to the ischemia, digital pain, and paresthesias, cold sensitivity, periodic blanching and discoloration of the fingers, and embolic associated syndromes as little flecks of debris flick off from the aneurysmal area to the distal circulation. You can get splinter hemorrhages in the subungual areas. You can get painful hemorrhagic foci in the pulps of the fingertips. The frequency of this syndrome, automechanics, it can occur in up to 14% of automechanics because they continually using their hands and vibrational injury associated tools, and vibration tool exposed workers up to 7%. In athletes, it's quite unusual, and rarely it's been described following a single episode of marked trauma, although virtually all cases are repeated episodes of vibratory injury to the canal. Advantages of surgical treatment in the hypothenar hammer syndrome is that A, you have removal of the painful mass. Secondly, you remove the source of distal emboli to the fingers, and you can relieve these aneurysms as they enlarge. They can cause radial nerve compression and injury, and you can relieve that with surgery. And basically, you're doing a periarterial sympathectomy when you do that. So if there's been an ischemic problem in the fingertips, they will typically improve with the surgery. And finally, you improve the ischemia, particularly if you reconstruct, as in this case, the ulnar artery. Further management of this syndrome, well, decreased exposure of microtrauma to the hands if possible, use of protective padded gloves, and you can use antiplatelet agents to treat these patients. And that's a brief case report and summary of the hypothenar-Hammer syndrome. And thank you for inviting me to present this for your conference.
Thank you, Dr. Charles. It was a very interesting case.